Good morning, ladies and gentlemen. I'm Dr. Armen Astvatsatryan from Yerevan, Armenia, and today we will talk about Stridor. Yes, so let's talk about Stridor. And first of all, Stridor. What is Stridor? Stridor is a high-pitched, predominantly inspiratory sound. Is the most commonly associated with acute disorders such as foreign body aspiration, but can be due to more chronic disorders such as tracheomalacia. You can hear. This is sound of Stridor. Once again, please. Yeah, once again. Okay, thanks a lot. Now, etiology and pathophysiology. Stridor is produced by the rapid turbulent flow of air through a narrowed or partially obstructed segment of extrathoracic upper airway. Involved areas include the pharynx, epiglottitis, larynx, and the extrathoracic area. So most causes manifest acutely, but some patients present with chronic or recurrent symptoms. Acute cases are usually infectious, except for foreign body and allergy. Chronic causes are usually congenital or acquired structural abnormalities of the upper airway. Transient or intermittent stridor can result from aspiration with acute laryngospasm or from vocal cord dysfunction. So the most common causes of acute stridor in children include croup, and beside croup, foreign body aspiration, epiglottitis. Epiglottitis has historically been a common cause of stridor in children, but its incidence has decreased since the introduction of the Haemophilus influenzae type B vaccine. Various congenital airway disorders can manifest as recurrent stridor in neonates and infants. Third was adults. Concerning adults, common cause in adults include vocal cord dysfunction, also called paradoxical vocal cord motion, post-extubation larynx edema, vocal cord edema or paralysis, larynx tumors, allergic reactions. Vocal cord dysfunction often mimics asthma. So many patients with vocal cord dysfunction are incorrectly given drugs for asthma but do not respond. Epiglottitis may be becoming more common among adults, but adults with epiglottitis are less likely than children to have a stridor. Okay, so once again about causes of stridor, some cause of stridor. Acute stridor, allergic reaction, it's severe. Sudden onset, suggestive findings. Sudden onset after exposure to allergen, usually accompanied wheezing and sometimes orofacial edema, itching, no fever or sore throat, cough rare. Diagnostic approach, clinical evaluation. Angioedema, another cause of stridor. Suggestive finding, often swelling of the face, lips and or tongue, often in people at risk, for example, exposure to allergen, use of ACE inhibitor, personal or family history, or hereditary angioedema. Diagnostic approach is a clinical evaluation, sometimes indirect laryngoscopy. And another cause of stridor, bacterial tracheitis, rare. Suggestive findings, breaking cough that is worse at night, high fever and respiratory distress, toxic appearance. Diagnostic approach. Next, neck X-rays, sometimes direct or indirect laryngoscopy with visualization, and culture of purulent tracheal secretions. So croup, suggestive findings: age 6 to 36 months, barking cough that is worse at night, uriae symptoms, upper respiration infection symptoms, no difficulty, upper respiratory infections, uriae symptoms, no difficulty swallowing, low-grade fever. Diagnostic approach in croup. Clinical evaluation, sometimes anteroposterior neck X-ray showing subglottic narrowing, stipple sign. Yeah, stipple sign. Another cause, epiglottitis. Suggestive findings: mainly adults as well as children who missed hip vaccination. Abrupt onset of high fever, sore throat, drooling, and often respiratory distress and marked anxiety. Toxic appearance. Diagnostic approach of epiglottitis: lateral neck X-ray if the patient is stable. Another diagnostic approach: examination in operating room if any signs of distress. Another cause: foreign body aspiration. Suggestive findings: sudden onset in a toddler or young child who has no uriae or constitutional symptoms. In adults, foreign body in upper airway, typically apparent by history. Diagnostic approach: direct or indirect laryngoscopy or bronchoscopy. Another cause, for example, inhalation injury, for example, due to cleaning agents, smoke inhalation. Suggestive finding: clinically apparent recent toxic inhalation. Diagnostic approach: clinical evaluation, sometimes bronchoscopy. Laryngospasm as a cause of stridor. Suggestive finding of laryngospasm, recurrent episodes associated with gastroesophageal reflux or recent drug use or occurring after endotracheal intubation. So diagnostic approach: direct or indirect laryngoscopy. Post-extubation complications, for example, laryngeal edema, laryngospasm, arytenoid dislocation. Suggestive findings: recent intubation and respiratory distress. Diagnostic approach: clinical evaluation, sometimes direct laryngoscopy. Another cause: retropharyngeal abscess, mainly in children less than 40 years as a suggestive finding. Another findings: high fevers, severe throat pain, drooling, trouble swallowing, sometimes respiratory distress. A swelling that may or may not be visible in the pharynx. Diagnostic approach: lateral neck X-ray, sometimes neck computed tomography with contrast. Another cause of stridor: vocal cord dysfunction. Suggesting findings: recurrent episodes of unexplained stridor, often with hoarseness, throat tightness, a choking sensation, and or cough. So diagnostic approach is direct laryngoscopy. Chronic stridor. Some cause of this chronic stridor: bilateral vocal cord paralysis or dysfunction. Suggestive findings: recent trauma, example during birth, thyroid or other neck surgery, intubation or deep airway suctioning, yeah. Various neurodegenerative or neuromuscular disorders present. Good voice quality but limited intensity. And diagnostic approach: direct or indirect laryngoscopy. Another cause of stridor: congenital abnormalities, numerous. Laryngomalacia, most common. Suggestive findings: usually in neonates or infants. Sometimes other congenital anomalies present. Sometimes trouble feeding or sleeping. sometimes worse with uriae. Diagnostic approach: computer tomography of neck and chest, direct laryngoscopy, spirometry with flow volume loops. Another cause of stridor: congenital tracheomalacia, suggesting findings: chronic symptoms, stridor or barky cough during coughing, crying, or feeding. May worsen in the supine position. Computer tomography diagnostic approach: computer tomography or MRI, spirometry with flow volume loops, sometimes bronchoscopy. Another cause of stridor: external compression. Suggestive findings is are history of head or neck cancer or obvious mass, night sweats, and weight loss. Diagnostic approach: X-ray of neck and chest, computer tomography of neck and chest, direct or indirect laryngoscopy. Another cause of stridor: laryngeal tumors, for example, squamous cell carcinoma, hemangiomas, small cell carcinoma, suggesting findings: inspiratory or biphasic stridor that may progressively worsen as tumors enlarge. And diagnostic approach: direct or indirect laryngoscopy, spirometry with flow volume loops. History. So if we talk about evaluation of stridor, of course we start with history. History of present illness should first identify whether symptoms are acute or chronic and whether transient or intermittent. If acute, any symptoms of upper respiratory infection, runny nose, fever, sore throat or allergy, itching, sneezing, facial swelling, rash, potential allergen exposure are noted. Recent intubation or neck surgery should be clinically obvious. If chronic, the age at onset, for example, since birth, since infancy, only until adulthood, and duration are determined, as well as whether symptoms are continuous or intermittent. For intermittent symptoms, provoking or exacerbating factors, for example, position, allergen exposure, cold, anxiety, feeding, crying, are sought. Important associated symptoms in all cases include cough, pain, drooling, respiratory distress, cyanosis, and difficulty feeling respiratory distress. Review of symptoms should seek symptoms suggesting causative disorders, including heartburn or other reflux symptoms, laryngospasm, night sweats, weight loss and fatigue, cancer, and voice change, trouble swallowing, and recurrent aspiration, neurologic disorders. Past medical history in children should cover perinatal history, particularly regarding need for endotracheal intubation, presence of known congenital abnormalities, and vaccination history, particularly HIV, Haemophilus influenza B. In adults, history of prior endotracheal intubation, tracheotomy, recurrent respiratory infections, and tobacco and alcohol use should be illicit. Physical evaluation. The first step is to determine the presence and degree of respiratory distress by evaluating vital signs, including pulse oximetry, and doing a quick examination. Signs of severe distress include cyanosis, decreased level of consciousness, low oxygen saturation, for example, less than 90%, air hunger, use of accessory inspirator muscles, and difficulty speaking. Children with epiglottitis may sit upright with arms based on the legs or examination table, lean forward, and hyperextend the neck with the low thrust forward and mouth open in an effort to enhance air exchange. Tripod position. Moderate distress is indicated by tachypnea, use of accessory muscles of respiration, and an intercostal retractions. If distress is severe, further examination is deferred until equipment and personnel are arranged for emergency management of the airway. Oropharyngeal examination of a patient, particularly a child with epiglottitis, may provoke anxiety, leading to functional obstruction and loss of the airway. So once again, if the patient's vital signs and airway are stable and acute, when suspicion is low and patients are in no distress, that they may undergo imaging. Others should be sent to operating room for direct laryngoscopy, which should be done by an otolaryngologist with the patient under anesthesia. If the patient's vital signs and airway are stable and acute epiglottitis is not suspected, the oral cavity should be thoroughly examined for pooled secretions, hypertrophic tonsils, induration, erythema, or foreign bodies. The neck is palpated for masses and tracheal deviation. Careful auscultation of the nose, oropharynx, neck, and chest may help discern the location of the stridor. Infants should be examined with special attention to craniofacial morphology, looking for signs of congenital malformations, patency of the nails, and cutaneous abnormalities. Red flags. The following findings are of particular concern: drooling and agitation, tripod position, cyanosis of hypoxemia on pulse oximetry, decreased level of consciousness. These are the red flags, my friends. So what about their interpretation? The distinction between acute and chronic stridor is important. Other clinical findings are also often helpful, of course. Acute manifestations are more likely to reflect an immediately life-threatening disorder. With these disorders, fever indicates infection. Fever plus barking cough suggests croup or, very rarely, tracheitis. Patients with croup typically have more prominent symptoms of upper respiratory infection and less of a toxic appearance. Fever without cough, particularly if accompanied by toxic appearance, sore throat, difficulty swallowing, or respiratory distress, suggests epiglottitis, and in young children, the less common retropharyngeal abscess. So drooling and tripod position are suggestive of epiglottitis, whereas retropharyngeal abscess may manifest with neck stiffness and inability to extend the neck. Patients without fever or symptoms and of upper respiratory infection may have an acute allergic reaction or aspirated foreign body. Acute allergic reaction severe enough to cause stridor usually has other manifestations or airway edema, for example, oral or facial edema, wheezing, or anaphylaxis, itching, urticaria. Foreign body obstruction of the upper airway that causes stridor is always acute, but may be occult in toddlers. Older children and adults can communicate the event unless there is a near complete airway obstruction, which will manifest as such, not as stridor. Cough is often present with foreign body, but rare with allergic reaction. Chronic stridor that begins early in childhood and without a clear inciting factor suggests a congenital anomaly or an upper airway tumor. In adults, heavy smoking and alcohol use should raise a suspicion of laryngeal cancer. Vocal cord paralysis usually has a clear precipitant, such as surgery or intubation, or is associated with other neurologic findings, such as muscle weakness. Patients with tracheomalacia frequently have cough productive of sputum and have a history of recurrent respiratory infections. Testing should include pulse oximetry. In patients with minimal respiratory distress, soft tissue next X-rays may help. An enlarged epiglottitis or retropharyngeal space can be seen on the lateral view, and the subepiglottic narrowing of croup steeple sign may be seen on the anterior-posterior view. X-ray may also identify foreign objects in the neck or chest. In other cases, direct laryngoscopy can detect vocal cord abnormalities, structural abnormalities, and tumors. Computed tomography of the neck and chest should be done if there is a concern about structural abnormality, such as an upper airway tumor or tracheomalacia. Flow volume loops can be useful in chronic and intermittent stridor to show the presence of an upper airway obstruction. Abnormal flow loop findings generally require follow-up with computer tomography or laryngoscopy. Now about treatment of stridor. Definitive treatment of stridor involves treating the underlying disorder, of course. As a temporizing measure in patients with severe distress, a mixture of helium and oxygen heliox improves airflow and reduces stridor in disorders of the large airway, such as post-extubation laryngeal edema, croup, and laryngeal tumors. The mechanism of action is thought to be reduced flow turbulence as a result of a lower density of helium compared with oxygen and nitrogen. Nebulized racemic epinephrine and dexamethasone may be helpful in patients in whom airway edema is the cause. And endotracheal intubation should be used to secure the airway in patients with advanced respiratory distress, impending loss of airway, or decreased level of consciousness. When significant edema is present, endotracheal intubation can be difficult, and emergency surgical airway measures, for example, sarcothyrotomy, tracheostomy, may be required. Okay, my friends, about key points. Inspiratory stridor is often a medical emergency. Assessment of vital signs and degree of respiratory distress is the first step. In some cases, securing the airway may be necessary before or in parallel with the physical examination, and acute epiglottitis is uncommon in children who have received Haemophilus influenzae type B vaccine. Okay, in conclusion, what I want to say, don't forget to make your donations. How to make these donations you can find in description of this video in YouTube or in podcast. So please be so kind and make your donations. It will be highly appreciated. And don't forget to follow and subscribe and put the ring on to be in touch with all news from our Dr. Weil channel news. Bye and God bless you.